So hello guys. So welcome to Medico. So we'll be starting with our first lesson, gastrointestinal diseases, part 1. In this part, we'll be discussing about inflammatory bowel disease, irritable bowel syndrome, and pseudomembranous colitis. And there will be a continuation to our next discussion. And in the next discussion, we'll be talking about gastroesophageal reflux disease and peptic ulcer disease. So in this lesson, I will be highlighting all the main points for you to keep in mind. You don't have to remember word by word, which is mentioned in the tutorial. Just try to remember the important points which I'm going to discuss here. Okay. So let's start off with inflammatory bowel disease. So inflammatory bowel disease, as the name suggests, it's an inflammation in the bowel. So there are two major forms. One is the Crohn's disease and the other one is the ulcerative colitis. So Crohn's disease can affect any part of the gastrointestinal tract. Ulcerative colitis can affect the colon. Usually it affects only the colon. Though these two are two different forms of inflammatory bowel disease, actually there's a degree of overlap between these two conditions when it comes to their clinical features, histological and also radiological abnormalities. So in this lesson, you have to remember what are the differentiating features of ulcerative colitis and Crohn's disease. How we are going to differentiate, you should be able to know. So ulcerative colitis, you all know that smoking can increase the risk of any disease condition. But when it comes to ulcerative colitis, smoking can reduce the risk. And in Crohn's disease, smoking can exacerbate this condition, and there is a increased risk with people who are experiencing a lot of stress. And when it comes to pathology, actually, when you see it using a colonoscopy, a patient with ulcerative colitis might have superficial inflammation of the colon. Okay, so if the rectum is involved, we call it as proctitis. So if this colon is affected, we call it as colitis. Usually sigmoid colon or the descending colon is usually affected. And in the pathology, like if we take a biopsy, you can see goblet cell depletion and also crypt abscess formation. So main highlighting point is there is a continuous superficial inflammation. Whereas in Crohn's disease, you get deep transmural inflammation, which means the entire thickness of the bowel wall is involved. There are patchy lesions as well. Patchy lesions in the sense, or what you call skip lesions. You get areas of inflammation and also areas which are inflammation free. So these are all skip lesions. You get areas of inflammations, and then there you get an area without any inflammation. Again, you get an area of inflammation, and then again you get an area without inflammation. And there are granulomas as well. Crypt abscesses are also present in Crohn's disease, but it is very rare, unlike in ulcerative colitis. So clinical features, patients with ulcerative colitis will have diarrhea with blood and mucus. Same as in Crohn's disease also, but Crohn's disease, the patient will have more features of weight loss and also right iliac fossa pain. Why? Right iliac fossa pain is mainly due to the involvement of the terminal ileum. And extraintestinal manifestations are much more common when it comes to Crohn's disease compared to ulcerative colitis. What are the extraintestinal manifestations which is present in both are hyperalbuminemia, pleural effusions, hypocalcemia, venous thrombosis, nephrolithiasis, which means kidney stone formation, iron deficiency anemia, usually normochromic normocytic anemia or iron anemia of chronic disease. Sclerosing cholangitis is much more common in ulcerative colitis. And also remember in Crohn's disease, what will happen is there will be an impaired enterohepatic circulation. Therefore, there is increased risk of gallstones and also increased risk of fatty liver as well. So when it comes to perianal diseases are much more common in Crohn's disease compared to ulcerative colitis. So what are the perianal diseases? You get anal fissures and also perianal or esophageal abscesses. You get hemorrhoids and skin tags. And in skin, you'll find skin lesions like erythema nodosum and pyoderma gangrenosum. And remember, usually patients with ulcerative colitis, or if there is an extensive Crohn's disease affecting the whole GI tract, then there will be an increased risk of bowel cancer. What? In other words, there's increased risk of colon cancer. In patients who is having sclerosing cholangitis, or if the patient is having a prolonged duration of this inflammatory bowel disease, which is untreated, then there's a risk of developing bowel cancer. So when it comes to growth and development, especially in children, there will be a poor growth. Because why? There is a colitis. So there will be impaired absorption of nutrients. Okay. And when a patient comes to you with blood and mucus diarrhea for prolonged duration, so in order for you to assess the condition of the patient, what will you do is you will first of all do a full blood count. And there you can see iron deficiency anemia. And also the ESR CRP might be high in both of these conditions. And if you are suspecting severe colitis in a patient with distended abdomen, profound constipation, or vomiting, you might have to suspect complications such as toxic megacolon as well. So in that case, you will have to order repeated supine abdomen X-rays to exclude this condition because it's much dangerous. And also there's an antibody called P-ANCA. It is positive in ulcerative colitis, whereas it is negative in Crohn's disease. So you can also observe the bowel using colonoscopy. You can do a colonoscopy, or you can do methods like capsule endoscopy or barium studies. So when it comes to the management, actually you should first of all understand that this inflammatory bowel disease actually doesn't have a specific etiopathogenesis. Okay, but it becomes increasingly clear that inflammatory bowel disease represents the interaction between several cofactors, usually genetic susceptibility coming into play, the environment, intestinal microbiota, and also the host immune response. Actually, there is no specific etiological factors for this, but it is due to interaction of many cofactors. Okay, so first of all, let's look at the management of Crohn's disease. Okay, so first of all, in Crohn's disease, the aim of the management is to induce and then maintain the clinical remission. By doing this, what you're going to achieve is you're going to achieve mucosal healing to prevent complications. Okay. But when you're managing a patient with Crohn's disease, it's very important for you to first of all exclude other conditions as well, other extraintestinal manifestations as well. So there can be malabsorptions, there can be sepsis, there can be stricture formation. So it's very important for you to exclude these first before starting immunosuppressives. As I've told earlier, host immune response also comes into play when it comes to the presentation of ulcerative colitis or Crohn's disease. So it's very important for you to first of all exclude these conditions, because if there are extraintestinal manifestations like this, bile salt malabsorption, or if there is stricture formation, or if there is extraintestinal sepsis, so then you can't start immunosuppressives. It can further worsen this condition. Okay. So patient with mild symptoms will only require symptomatic management. Okay, now let's look at how are we going to induce remission first. So for Crohn's disease, first of all, to induce remission, to induce mucosal healing, what you can do is you can either start a steroid, either oral or IV glucocorticosteroid, and then you can continue on enteral nutrition. Okay, and also, as I said earlier, host immune response also comes into play. Therefore, there's a place for anti-TNF antibodies, anti-tumor necrosis factor antibodies you can start. So these anti-TNF antibodies, even you can continue it during the maintenance of remission also. And to maintain remission, sometimes immunosuppressives like azathioprine can also be used. There are other drugs as well, like mycophenolate mofetil, methotrexate also can be used to maintain the remission. For perianal disease, you can use ciprofloxacin, metronidazole, azathioprine, and TNF antibodies. Okay. So moving on to ulcerative colitis management. So usually, when it comes to ulcerative colitis, you should have a patient-focused management. Okay, and also you should have full access to a multidisciplinary team approach. But depending on the severity of the condition, we can divide the management. For mild to moderate disease, you can use a aminosalicylate, which can act topically in the colonic lumen. Okay. Usually, you use 5-aminosalicylate. So, for conditions like proctitis, you can use a rectal 5-aminosalicylate suppository. Or if the colon is involved, you can go for 5-aminosalicylate enema's. Okay. So, in case of extensive colitis, there's a place for oral 5-aminosalicylate as well. Okay, you can use an adequate dose. Suppose if a patient is present with a severe colitis condition, then what you can do is, since there can be a flare-up sometimes, you can use oral prednisolone or you can use IV hydrocortisone 100 milligram IV 6 hourly. So as I have told earlier, sometimes the severe colitis patients might present with venous thrombosis. So you can have a thromboprophylaxis. So with low molecular weight heparin to prevent thromboembolism. Understood? And also, there is also a place for surgery as well. Okay. So when it comes to acute disease, subtotal colectomy with end ileostomy and preservation of the rectum is the operation of choice. Okay. So remember, there is also a place for surgical management as well. Understood? So that's all for the management of ulcerative colitis and Crohn's disease. So what you should remember is, you should remember the extraintestinal manifestations and what extraintestinal manifestations are common for Crohn's and what are common for ulcerative colitis. The main differentiating features when it comes to pathology and also the management. Okay, how are you going to manage? and what investigations would you like to carry out? Okay. And now moving on to irritable bowel syndrome. So this irritable bowel syndrome is another functional class of bowel diseases, functional diseases. Okay, actually they present with non-specific symptoms. Sometimes a patient with irritable bowel syndrome might have other kind of psychological or physical traumas. Okay, so those can be precipitants sometimes, and also even stress comes into play here, and also the symptoms and signs which are common in irritable bowel syndrome are very non-specific. Okay, it can be associated with dyspareunia, dysmenorrhea, increased urinary frequency. Okay, and also there will be a cramping abdominal pain. So abdominal pain might sometimes get relieved with defecation. And also remember, the Rome criteria suggests that the symptoms must be present in the preceding 3 months. Okay. Rome 3 criteria in 2006 suggests that the symptoms should be present in those preceding 3 months. Okay. And at least 3 days per month, the symptoms should be present. And the onset should be related to stool. The onset should be related to different or varied stool frequency. Okay, and also the stool frequency is change, and also the consistency might also change. Okay, so the Rome 3 criteria again suggests what it suggests is the symptoms should be present for the preceding 3 months, and at least 3 days per month the symptoms should be present, and the abdominal pain should be relieved after defecation, and the abdominal pain is associated, or the onset is associated with a change in stool frequency, or the onset should be present with a changing stool. There should be a changing stool consistency as well. Frequency and stool. Frequency and also the type of stool will vary. So here the management is mainly conservative. We can use laxatives if there is constipation, and you can avoid precipitants such as the diet, and also antispasmodics can be used. You can use prokinetics like domperidone, or you can go for this lifestyle modifications. Can reduce stress, and you can also increase the fluid intake and fiber diet and see whether the symptoms get relieved. Okay, and also remember IBS. Sometimes there are recent studies suggest that use of these prebiotics and probiotics will also alter this gastrointestinal normal flora, and it will help in relieving certain symptoms like bloating and abdominal pain. Okay, so in this part what you should remember is that irritable bowel syndrome fall under functional gastrointestinal disorders, and actually it is a multi-system disorder. There are specific, non-specific symptoms, and also it is mainly conservative management. Okay, and there are no sinister features, and there is no risk of cancer here. Okay, and also the diagnostic criteria is the Rome 3 2006 criteria, and the criteria state that the symptoms should proceed in the 3 months, and at least there should be 3 days per month with recurrent abdominal pain associated with improvement of the symptoms with defecation, and the onset should be associated with a change in frequency of stool, and the onset should be associated with a change in the form or the appearance or the consistency of stool. So these three things you should remember. Okay. So, and the management is mainly conservative. So that's all for irritable bowel syndrome. So moving on to pseudomembranous colitis. So pseudomembranous colitis is very easy. What you all should keep in mind is pseudomembranous colitis is caused by an infection with Clostridium difficile, and it mainly affects elderly patients who might be taking some antibiotics like ampicillin, clindamycin, fluoroquinolones, or cephalosporins, or in patients who have stopped the antibiotic course. Okay. Actually, there are two toxins released by this Clostridium difficile. One is the toxin A and toxin B. So toxin B is a cytotoxin actually. Because of that only, sometimes the patient might get a bloody diarrhea. Okay. Toxin A is a enterotoxin. So in patients with pseudomembranous colitis, there can be a profuse diarrhea, and sometimes there can be a bloody diarrhea as well. So usually how we are going to manage these patients are, first of all, we can stop that antibiotic course and you can prescribe metronidazole or vancomycin up to 14 days. But usually it get resolved. But in 20% of the time, sometimes it can reoccur. Okay. So what you should keep in mind is pseudomembranous colitis is due to Clostridium difficile infection, and it is usually due to antibiotic usage, and it starts in elderly patients after antibiotic usage. Antibiotics which cause it are ampicillin, clindamycin, fluoroquinolones, and cephalosporin. And usually in severe cases, doctors will prescribe metronidazole or vancomycin or fidaxomicin for up to 14 days. That's all you should keep in mind. Okay, guys. So our next topic will be gastroesophageal reflux disease and peptic ulcer disease. So we'll be continuing that part in our next discussion. So if you have any problems, please list it in the comment section below. Or if there are any recommendations or any points for I have to improve on, please mention them in the comment section. I will respond to it soon. So guys, thank you very much. So we'll meet with our next discussion on gastroesophageal reflux disease and peptic ulcer disease. Thank you.